Good morning. Welcome to the Barts Cardiovascular Simulation Lab. I'm Dr. Khalid Barakat, Director of Cardiovascular Simulation at Barts. So this morning we've got some simulation-based DOPS set up for you to see, and the objectives today are for you to understand how to use simulation in setting up DOPS for cardiology trainees, and this is particularly pertinent at the moment with the COVID pandemic. I think when setting up simulation-based DOPS, it's important to understand that it's nearly impossible for most of these types of DOPS to assess them in just one station or one type of sitting. We have to break down the objectives that we're assessing into different stations so that we can assess them appropriately to the level expected by the curriculum. The advantage of simulation-based DOPS, I think, is that it allows for a much more interactive and formative discussion with the trainee, and therefore potentially a higher quality of DOP. So the first DOP that we're going to show you is DC Cardioversion, and the very first station within that is a simulated patient.
Hi there, my name is Kyriacos Mouyis. I'm one of the cardiology doctors.
Hello.
So you've come today for a procedure called DC Cardioversion.
Yep.
Can you tell me a bit about the symptoms that brought you in?
Well, my heart rate is very fast, and when I go for like a brisk walk, I get really short of breath. So they said that the best thing to do was to sort of have me shocked out of it. They did start me on some medication about 6 weeks ago, some rivaroxaban and bisoprolol. I've got a history of hypertension, so I'm normally on amlodipine for that. But yeah, just here today to hopefully get this sorted.
Sure. So apart from the shortness of breath, are you experiencing any other symptoms?
No.
So you're not getting any chest pain at all?
Nope.
Or any palpitations?
Nope.
Okay. And have you noticed your legs swelling at all?
No.
No. Okay. And apart from the high blood pressure, do you have any other health problems?
No.
And do you take any other medications except for rivaroxaban and bisoprolol?
Just the amlodipine.
And the amlodipine?
Yep.
Okay. And do you have any allergies to any medication?
No allergies.
And any family history of any other health problems?
No family history.
Okay. So as I said earlier, you've come in for a procedure called DC Cardioversion. The objective of the procedure is to restore the normal heart rhythm and hopefully help with alleviating the symptoms that you're experiencing. I'll explain a bit about the procedure now. So we're going to come into the procedure room where there will be a big team looking after you. Make sure you're comfortable. We'll put some pads on the front of the chest and also onto your back. Okay, and we'll give you some medications to relax you and make sure the procedure is not uncomfortable and you don't experience any pain.
Okay, well that's good.
Yeah, so we'll make sure you're comfortable, as I said, and then we'll, using the pads, apply an electrical shock essentially to the heart to try and restore the normal heart rhythm. You shouldn't be feeling that, or you shouldn't be feeling any pain or discomfort. If you do experience something, we'll make sure that we'll give you more sedation to help with that. The whole procedure shouldn't last more than half an hour. As with any procedure we do, there's always a small risk of potential complications, but the procedure is more than 99% safe. The commonest problem we face is being unable to restore the normal heart rhythm of the heart, so the procedure is not successful.
So it might not work. Okay.
Unfortunately, that's the commonest problem we face with the procedure.
Okay.
Other small issues, as I said, could be feeling some discomfort or pain when we administer the shock. We'll try and deal with that by giving you more sedation. Much less common, rare actually, side effects are more severe include the risk of a stroke or the risk of the heart going to a dangerous heart rhythm that we may need to shock you out of again.
Okay.
Do you have any questions about the...
So my only worry is that my heart won't restart, and obviously I get that it might not get me out of this funny heart rhythm, but it will restart. Yeah,
so the heart will always restart. As I said, it could be in the same rhythm as before, but the heart will always restart.
Okay. And my husband's coming to pick me up later, but I'm not to drive for the rest of the day?
Yes, so you shouldn't drive going out because we're giving you sedation. It can make you sleepy and makes
But I shouldn't need
driving
to stay in
dangerous.
hospital overnight. I should be able to go home later.
You should be able to go home later today, and once you go home, and once you're not feeling sleepy or drowsy, you'll be able to resume your normal activities. As
Okay,
before.
so I can go for a walk and do normal things.
Yes,
No
you
restrictions, really.
Yes, you can, no restrictions.
Okay,
Great.
thank you. Thank you very much.
Hi, Kyriacos. I think you're doing the DC Cardioversion with me today, aren't you?
Yes.
Brilliant. So who's first on the list?
So we've got a 40-year-old lady who's been recently diagnosed with atrial fibrillation a few weeks ago. She describes feeling quite short of breath on exertion, unable to do her daily activities, no other symptoms of note.
Okay.
And she's been started on rivaroxaban, bisoprolol, by her doctor. She's also got high blood pressure, is taking amlodipine for that. She's otherwise a fit and well lady.
Okay.
She's quite keen to get rid of her symptoms.
Fine. So in terms of other investigations, has she had any bloods recently?
She's had bloods recently. She's got normal full blood count.
Okay.
And her electrolytes are normal as well. I think her potassium was 4.5. She had a magnesium that was 1.0.
Okay. And presumably at some stage she's had thyroid, has she, and echoes?
Yeah, so she's had thyroid function performed as well. That's normal.
Okay.
No thyroid issues. And her echocardiogram was normal as well, no structural abnormalities.
Okay. So you mentioned the magnesium and the potassium. Are there any situations where you wouldn't proceed with a cardioversion if there was an abnormality with the potassium or magnesium?
Yeah, I think if she had a very low magnesium, I'll definitely try and replace that. And also if the potassium was in the abnormal range especially, I would try and normalize that before proceeding.
Okay. Would you ever do a cardioversion without any bloods? An elective one?
No, I think we should, in elective cases, especially because she's otherwise well lady, we need to make sure there's no other issues before proceeding.
So how are we planning to do this one then? Are we going to get an anaesthetist and?
Yeah, I think I've just called the anaesthetist because it's an elective list. I think we'll need decent help. It's not an emergency. I don't think there's any urgency to do without the appropriate assistance.
And when you do these cardioversions, what kind of paddle positions do you like?
So in these elective cases especially, because the patient is mobile, I think an AP position is probably best, but we can also do anterolateral position as well. Also depends on the body habitus and also where it's easier to place them. If there's any other devices inserted as well, that might affect our decision.
So in this particular case, what are you going to do?
I think in this case we can use an AP position
Okay.
for this lady, anterior posterior.
So you say she's been on rivaroxaban. So let's just say we were rate controlling her, not DC cardioverting her. Would you anticoagulate her long term?
Yes, if we kept her in with a rate control rather than control strategy, she's a female, she's hypertensive, so based on the child's vascular, I think we should be anticoagulating her.
So there's a robust case there, isn't there? Mm-hmm. And she's been on it for 6 weeks, you say?
Yeah, she's been on it for...
So there's all this sort of empirical stuff, isn't there, about them being on it for a minimum of 4 to 6 weeks. Now, if someone comes in and they've only been on rivaroxaban for 3 weeks, would you cancel, delay, defer? What would you do? Or would you just carry on with the cardioversion?
So if it's an elective case, I guess we've got two options. We can either do a TOE guided cardioversion or defer until we've got a few more weeks. I think it will depend on the clinical state of the patient, to be honest. If they're stable and elective and happy to be waited, I would probably defer them for a bit longer. But in an emergency situation, obviously we don't have many options. You probably have to proceed with the TOE if you can.
Okay, and just remind me for the rationale for TOE-based cardioversion with short anticoagulation.
So that's to exclude the presence of thrombus in the left atrial appendage and ensure that there's not a high risk of stroke, essentially, when we cardioverse the patient's temporary embolic phenomena.
Brilliant, thank you. So shall we go to the OR and proceed? Hi Kyriacos, so we're now ready to do the cardioversion, so we're going to use this defibrillator. Are you familiar with this defibrillator?
Yes. So this is the life pack that we use in the trust. It's currently in AED mode. If I open this door, it goes into manual mode. It's displaying the rhythm there. We know it's on. Step 2 is the selection of energy. So for the cardioversion, we're going to use maximum biphasic energy at 360 joules. So
Is that what you always do?
yeah, there's been recent evidence that's shown that 360 joules maximum deliverable energy gives better rates of cardioversion. So that's what we use now. And after we select the energy, it's obviously important to sync. So pressing the sync button, that goes on, and the triangles on top of every QRS complex shows us that it's syncing with the patient to avoid any R on T phenomena that could put the patient into ventricular fibrillation. We know it's synced. We can then charge, and then once it's fully charged, we'll deliver the shock with the red button.
Okay.
Once we charge, if we want to dump the charge and not use it, we can do it by pressing this button here.
Very good.
And it's dumped the charge.
And these two leads, what are they? Just talk me through them.
So this one here connects to our pads, so they will go on here and then be connected to the patient.
Okay.
And this is for the 3-lead monitoring.
Okay. And you can also monitor through the pads.
And you can also monitor through the pads, and we can change which we use to monitor through here. Choose one of the 3 leads or the pads.
Very good.
So now we're monitoring through lead 2.
And what are these buttons for here?
So this is for other functions of the life pack. This is for pacing, essentially. You can switch it on from here, choose the rate we want to pace in, and then choose the current we want to deliver to ensure electrical and mechanical capture.
And can you pace through the defibrillation paddles?
So yeah, we can perform transcutaneous pacing through the pads if we have to in emergency situations, which would be uncomfortable for the patient, but we can, if have to in emergency situations, deliver that, yeah.
Okay, thank you. Kyriacos, so we've done the WHO.
Yes, we've done the checklist.
And we've introduced each other, so that's all fine. So, and you've placed the paddles. In what position have you placed them?
So we've placed them in the anterolateral position under the right clavicle and on the left side, just under the left axilla.
Brilliant. Okay, I'll let you two get on with it then.
Okay. Amanda, are you happy with the sedation?
Okay, so I'm happy with sedation and I'm ready whenever you are.
Okay, great, thank you. So I'm just going to make sure we are monitoring through the paddles, which we are. Going to select the appropriate energy. So we're going up to 360 joules maximum biphasic energy. So we're going to sync. So sync is on. It's a triangle above each QRS complex. Okay, I'm about to start charging. So Amanda, can you stand back, please? Clear the patient. So I'm charging. Okay, so all clear, shocking. Okay, so can go back to living oxygen, Amanda. So I'm just checking the defib now, and from here I can see that we're still in AF. I'll also have a quick look at the pulse and confirm that. Yeah, the patient is still in AF. So I think we've delivered one shock now that's been unsuccessful. I think we should change the position of the pads from an anterolateral to an anteroposterior position. So we're just gonna reposition them now. So we should leave the one in the front on. So we've now got the paddles in the AP position. Let me know when you're ready, Amanda.
I'm ready, I'm happy.
Okay, thank you. So first make sure we are still, we're monitoring through the paddles. Select the appropriate energy. 360 joules biphasic, that's the maximum energy. So now we need to sync, and I got a triangle above every QRS complex, so we are synced. So can I ask you to stand back now with the oxygen? So we will charge. Okay, so all clear, everyone clear? Shocking. shock delivered. We can go back with the oxygen. So we've got sinus rhythm on the screen. Could we cycle the blood pressure, please? I'll have a check for the pulse. And I can feel a pulse. It's regular, the rate of about 80, same as the monitor. And I think the blood pressure is also
blood pressure cycling.
got better. Great.
So the blood pressure is up to 120 over 79.
over 79. Thank you.
Great, Kyriacos. What's happened then? Tell me.
So we managed to cardivert the patient back into sinus rhythm after 2 shocks.
Okay.
First one was delivered in an anterolateral pad position, 360 joules, unsuccessful. We swapped over into the AP position and we were successful after 1 shock at 360 joules.
Great. I thought you did that very well. One question I've got is why were you switching to paddles for ECG monitoring? Because we've got perfectly good ECG monitoring.
Yes, we could have used the 3 leads. Actually, that's the use of the 3 leads because it can give us an alternative way of monitoring. The pads can be unreliable, so I could have used lead monitoring through any of those 3 leads that we had on there.
And when we do use 3 lead monitoring, what's the rationale usually of using lead 2?
So it's because of the position that it monitors the heart from. I'm actually not actually sure.
Yeah, that's generally true, but I think P waves tend to be generally larger in that position,
Yes.
don't they? Just because of the axis that the P waves generate. Yeah, electrical axis. Traditionally, that's what you will find. Okay, so this patient's now, sorry, you were going to say?
No, it's fine.
Yeah, so this patient's now back in sinus rhythm. So to recap, she was what, 40, 6-week history of symptomatic AF, back in sinus. So what are you going to do with her meds?
So I think at this instance we should continue the anticoagulation for another 4 weeks, which is a period during which there might still be embolic phenomena. The patient might go into AF, which may revert back. So we should continue the anticoagulation. And the beta blocker, we can continue, but if she becomes bradycardic, we can also stop it. It's not mandated necessarily because doesn't really help maintain the patient in sinus rhythm.
Okay, so just let's touch on the medication. So you said 4 weeks. What would you do at 4 weeks if she's in sinus rhythm?
We can stop the anticoagulation, but we need to have evidence that she's not into AF.
Okay.
Again.
So there have been some trials, haven't there? Affirm comes to mind, where people have done exactly what you've said, which is cardiovert people, and then at 4 weeks see if they're in sinus rhythm, and then they've got randomized if they were in sinus rhythm to an anticoagulant versus stopping the anticoagulant. Can you remember what happened at 1 year with that group of patients?
So I think that there is a benefit in continuing anticoagulation actually in this patient, especially because he has a high CHAS-VASc score. So
Exactly. So, and the patients that are most likely to go back into AF are
sort of older female
hypertensives. So they've got a high likelihood of recurrence. So you need to continue the anticoagulation. She's got a CHAS-VASc score of 2, hasn't she? And there's a chance she will go into AF at some stage. Okay. Very good. And in terms of discharge home today?
So if she's well and she recovers from the sedation, there's no problem. She can go home today. As we said, she should not drive home because of the sedation, but she'll be safe to go home later.
Good. Any questions about this procedure?
No, thank you.
Brilliant. Okay, thank you.